So, hello again, everyone. Hello, and welcome to Module 4, Part 2. We are now on the second part of our module, and for today's topic, we are going to discuss about mood disorders and suicide. So, in this lesson, we are going to talk about more depression, bipolar disorders. So those are the focus of this lesson. So we also will talk a little bit more about suicide later on. So without further ado, let's begin our journey in mood disorders and suicide. So first on the list are depressive disorders. So the first one is major depressive disorder. So let's first define what is depression. So everyone occasionally feels sad and may even characterize their mood as depressed every once in a while. However, these feelings are usually short-lived and pass within a couple of days. When you have clinical depression, it interferes with your daily life and causes significant pain for both you and those you care about. Major depressive disorder is also known as major depression and clinical depression. And it's a mood disorder characterized by pervasive and persistent low mood that is accompanied by low self-esteem and by loss in interest or pleasure in normally enjoyable activities. So, what do we call loss in interest or pleasure in normally enjoyable activities? So, it is also known as anhedonia. The symptoms usually interferes with the person's ability to work, sleep, study, eat, and enjoy pleasurable activities. So, as you can see, it's really causes distress to a person and at the same time dysfunction to his or her life. Let's now go into the DSM diagnostic criteria for MDD or major depressive disorder. So the diagnostic criteria for MDD are the following. Letter A, 5 or more of the following symptoms have been present during the same 2-week period and represent a change from previous functioning. At least one of the symptoms is either 1. Depressed mood, or 2. Loss of interest or pleasure. The specific symptoms for letter A are number 1. Depressed mood most of the day, nearly every day, as indicated by either a subjective report. So for example, the patient feels sad, empty, or hopeless, or observation made by others. So for example, always appears tearful. So for children and adolescents, this can be an irritable mood. So number 2, markedly diminished interest or pleasure in all or almost all activities of the most day, nearly every day, as indicated by either subjective account or observation. So like I said, anhedonia. So you lost pleasure in your hobbies, you lost pleasure in your work, you lost pleasure in your daily activities. Number 3 is significant weight loss when not dieting or weight gain. Example, a change of more than 5% of body weight in a month, or decrease or increase in appetite nearly every day. So note, in children, consider failure to make expected weight gain. So there is significant weight loss or weight gain. So some people, their way of coping is through eating. But if it's a very sudden change in body weight, like 5% in a month, or there is also a sudden decrease in weight that is not normal when you are going to diet. So that may be a sign of depression. So number 4, insomnia or hypersomnia nearly every day. So in insomnia, either the person cannot sleep throughout or cannot initiate to sleep, or has awakened but is unable to sleep again. So there is also psychomotor agitation or retardation nearly every day. So it is also observable by others, not merely subjective feelings of restlessness or being slowed down. So agitation means the person seems to be restless, and retardation means that the person seemingly is sluggish, is on bed all day. So it's nearly every day, and it's also observable by others and not just a subjective feeling of slowness or being slowed down. So in depression, like I said, everything slows down. You feel as though everything slows down and you don't have that energy to interact with others. So, number 6, fatigue or loss of energy nearly every day. So, normally when you go to sleep, you have been refreshed with your energy, or somehow your energy has been refreshed for a reason. Your energy has been full for when you go to sleep or when you feel rested. But in depression, the fatigue seems to not wear off even after sleep. So like it's when you wake up and then you still feel tired, or somehow you lose your energy. You feel like you don't have the energy to work nearly every day. So there's also feelings of worthlessness or excessive or inappropriate guilt. So which may be delusional. So nearly every day. And it's not merely a self-reproach or guilt about being sick. So and feelings of worthlessness, so you feel that nobody needs you, or excessive or inappropriate guilt. So you feel that, for example, when you made a mistake, small minor mistake, you feel that very, very guilty, or you have excessive guilt, and it affects your self-esteem. So there is also a diminished ability to think or concentrate, or indecisiveness nearly every day, either by subjective account or as observed by others. So patients with depression, since they feel that everything is slowing down, sometimes they cannot think or concentrate in one area, and sometimes they feel indecisive. So for example, if you are on your depressive episode and then you take a test, so you cannot finish the test because not only you don't have any energy, but because you cannot think or decide, and it's nearly every day. So there's also recurrent thoughts of death, and not just fear of dying. So there's also recurrent suicidal ideation without a specific plan or a suicide attempt or a specific plan for committing suicide. So here, a sign that a person might have depression is because of they have recurrent thoughts of death. Okay, so they think of ways of how to kill themselves. So sometimes ideations, so ideations is just thoughts. So sometimes it has no specific plan, but it will become a danger zone when there is already a specific plan. So there is a time, there is a place, and there is a method, and there is already an attempt. So if there's already an attempt, so possibly the person may have depression. So I said may because it's not only limited to depression that there is a suicide risk. So it's not only limited to depression. Someone who has substance use disorder can think of suicide, can attempt suicide. Someone who has bipolar disorder can also attempt suicide. And someone who has anxiety disorder can also attempt suicide. So it's not just specific to one disorder. So that's why there's always a suicide risk in some disorders there. So in their prevalence. So of course, letter B and C are the clauses, the dysfunction clause and the medical condition clause. There's a note. So in 2013, the DSM-5 removed the bereavement clause from the diagnostic criteria MDD. So this means that those who were previously exempt from the diagnosis of MDD due to bereavement, so mourning the loss of a loved one, are now candidates for MDD diagnosis. So it means that it's better to observe people who lost their loved ones because they are possible candidates for MDD. Before, they exempt people who respond to significant loss like bereavement, financial ruin, losses from a natural disaster, a serious medical illness, or disability. So before, they excluded that. So they have a different note, but today they are now possible candidates for depression. That's why, for example, if you lost somebody or you lost something or there's a significant loss in your life, like for example, during a calamity, so that's why prevention is there. That's why psychological first aid is there, so that those intense feelings of sadness, so that you can make sense or the person can make sense of the feelings of sadness that he felt, the loss that he felt during that time. Cluster D and E are the clause for schizophrenia spectrum, and of course, the letter E is a clause for bipolar disorder. So next, this disorder or next depressive disorder is persistent depressive disorder. So in 2013, the DSM-5 released a new diagnosis called persistent depressive disorder. So this diagnosis combines previous disorder of chronic major depressive disorder and dysthymic disorder. So diagnosis requires that a person experience depressed mood most of the day, nearly every day for at least 2 years, as well as 2 of the other symptoms of major depressive disorder. So people with persistent depressive disorder are chronically sad and melancholy, but they do not meet all criteria for major depression. So the etiology and treatment of persistent depressive disorder is much the same as MDD. So just to add on to my second to the last point, so people with the persistent depressive disorder are chronically sad and melancholy but do not meet all criteria for major depression. So, however, episodes of full-blown major depressive disorder can occur during persistent depressive disorder. So this is the diagnostic criteria for persistent depressive disorder or dysthymia. The only difference between MDD and persistent depressive disorder is first, the time limit. So at least 2 years before your clinician can diagnose you with PDD. So also present while depressed 2 or more of the following. So it's somehow same with MDD. But again, the individual did not fulfill the criteria A and B for more than 2 months at a time. And also, MDD may be present for 2 years. And of course, the E and F cluster is for the bipolar clause and the schizophrenia clause. Now, let's proceed to the second mood disorders that we are going to talk about, which are bipolar disorders. So, what are bipolar disorders? So, bipolar disorders are debilitating mood disorders characterized by periods of mania or hypomania and periods of depression. So, it is also known as manic depression. And it is a mood disorder characterized by periods of elevated mood and periods of depression. So, the elevated mood is significant and is known as mania and hypomania, depending on the severity or whether there is psychosis. Both manic and depressive episodes are so intense that they interfere with everyday life. Between cycles of manic and depressive states, the individual will often experience normal functioning. So the risk of suicide among those with the disorder is higher or is high at greater than 6% over 20 years, while self-harm occurs in 30 to 40% of patients. Other mental disorders are such as anxiety disorders and substance use disorders are commonly associated. Before we go into the diagnostic criteria, so let's go to define the term bipolar spectrum. So the bipolar spectrum refers to the range in which these alternating moods may occur, and it includes bipolar 1, bipolar 2, and cyclothymia, and other specified bipolar and related disorder. For all of these diagnoses to be made, the symptoms must indicate a major change from a person's typical mood. Let's define now what are manic episodes, mixed episodes, and of course, a major depressive episode. So, a manic episode is a distinct period of elevated or irritable mood, which can take the form of euphoria. So, people with mania commonly experience an increase in energy and a decreased need for sleep, with many often getting as little to 3 or 4 hours of sleep per night. Some can go days without sleeping. So, I will explain more further what is mania in the diagnostic criteria. So, how about mixed episodes? So, a mixed episodes is a condition during which symptoms of mania and depression occur simultaneously. So, typical examples include weeping during a manic episode, experiencing racing thoughts during a depressive episode, or thinking grandiose thoughts while at the same time feeling like a failure. Mixed states are often the most dangerous periods of mood disorder, during which the risk of substance abuse, panic disorder, suicide attempts, and other complications significantly increase. What is a major depressive episode? So, a major depressive episode is not required for the diagnosis of bipolar 1, although it frequently occurs. The depressive phase includes persistent feelings of sadness, anxiety, guilt, anger, isolation, hopelessness, disturbances in sleep and appetite, fatigue, loss of interest in usually enjoyable activities, problems concentrating, loneliness, self-loathing, apathy, and or indifference. So, a major depressive episodes persist for at least 2 weeks. So, let's now take into a deep dive onto mania. What is mania? So, in bipolar 1, so it is necessary to meet the following criteria for manic episode. The manic episode may have been preceded by and may be followed by hypomanic or major depressive episodes. So, later on, we will differentiate bipolar 1 and bipolar 2. But first, let's see what is a manic episode. So, a manic episode is a distinct period of abnormally and persistently elevated, expansive, or irritable mood. And abnormally and persistently increased goal-directed activity or energy lasting at least 1 week and present most of the day, nearly every day, and or any duration if hospitalization is necessary. Okay? So, again, there is a distinct period of elevated. So, you feel sky high, expansive, or irritable mood. So, the elevated and expansive mood is very much abnormal. So, sometimes you feel very confident for no particular reason, or when there is irritability, so you get easily angered or you feel like you are going to blow up. And it's also abnormal because it's lasting for at least a week. So people can observe that. And there is also letter B. There is an increased energy and there is also an increase in goal-directed activity or energy lasting at least a week. So for example, you are very energetic in your specific work. So for example, you feel like you can do your research in just 1 week. You have that energy, extreme energy to do that. Not only you have an elevated mood. During the period of mood disturbance and increased energy or activity, 3 or more of the following symptoms, 4 if the mood is only irritable, are present to a significant degree and represent a usual change in behavior. So the first one is, of course, inflated self-esteem or grandiosity. So you, like I said, you feel super confident or you feel grandiose, feel like you're on the top of the world. So like that. So there's also a decreased need for sleep. Sometimes you feel rested after 3 hours of sleep. As you can see in manic episodes, sometimes this is also in line with that increase in goal-directed activity or energy. So there is also more talkative than usual or pressure to keep talking. So you as a clinician must also take into consideration if really the person is talkative naturally, or for example, if the person is not talkative usually, so there is an increase or there's a pressure for him or her to keep talking. And another, for example, if really the person is really talkative, so you feel that the person talks nonstop. So there's also flight of ideas or subjective experience that thoughts are racing. So for a person who has bipolar disorder, everything is super fast. They feel that everything revolves and sometimes they are disoriented already with the time. So like everything is so fast. So if you compare it to depression, everything is super slow. For bipolar, it's super fast. Everything is super fast. So there's also distractibility. So for example, their attention is too easily drawn to unimportant or irrelevant external stimuli as reported or observed. So for example, while you are listening to the teacher's lesson, your dog barked, so your attention was drawn now to the dog and you fail to go back and listen to your teacher. There is also increase in goal-directed activities, so either socially, at work, or school, or sexually, or psychomotor agitation, so purposeless, non-goal-directed activities. So like I said, some people with bipolar disorder, they think, for example, they think that they can finish their thesis in 1 week, or for example, they go into investments quickly, or if they discovered a new hobby, there is an increase in interest in that activity. Like you feel like you are going to finish an artwork in a week or in a day. So there's also excessive involvement in activities that have a high potential for painful consequences, such as engaging in unrestrained buying sprees, sexual indiscretions, or foolish business investments. So since you got the feelings of grandiosity and you feel that you are on the top of the world. So for example, in a day and you were just scrolling Shopee and then you checked out all of your cart's content without thinking of the consequence, whether you can afford all of it or whether you have money left, or for example, investing money into something without taking into consideration your savings, whether that business or investment is a scam or not. So something like that. So you do that on impulse because you have that feeling of elevated or expansive mood. Of course, letter C is the dysfunction clause. So one thing to notice in the letter C is that those who are diagnosed with bipolar 1 have a necessity to be hospitalized because of the activities that they are doing, and that is to prevent harm to self or others, or if there are psychotic features. So psychotic features such as delusions, so oftentimes it's more of the delusions. Some experience hallucinations, especially voice hallucinations, and of course, letter D is substance use clause. So in here, at least one lifetime of a manic episode is required for the diagnosis of bipolar 1 disorder. So, once you check all the boxes for a manic episode, immediately the diagnosis will be bipolar 1. So, what is a hypomanic episode? So, it's almost the same as manic, but in hypomanic episodes, it's at least 4 consecutive days. So, unlike in manic, it's 2 weeks. There's also another, so it's almost the same. The difference is at least 4 consecutive days. There's also an equivocal change in functioning that is uncharacteristic of the individual when not symptomatic. So there is a significant change in mood. So the mood and change in functioning are observable by others. But another difference again is it is not enough to cause marked impairment. So there is no need for a person to be hospitalized and there is no psychotic features. And of course, the F clause is the substance use clause. And here, the note, hypomanic episodes are common in bipolar 1 but is not required for the diagnosis of bipolar 1 disorder. Okay, so again, the differences in manic and hypomanic. So the first one is the time. In manic, at least 2 weeks. For hypomanic, at least 4 consecutive days. So also, the difference between manic and hypomanic is that in manic, there is an unequivocal change in functioning that is uncharacteristic when the person is in normal mood. So there is also a change in mood and functioning that is observable by others. And also, one of the clear differences is that it's not enough to cause marked impairment. So it's not so severe that the person needed to be hospitalized. And of course, there is no psychotic features. What now are the difference between bipolar 1 and bipolar 2? So, for you to diagnose someone with bipolar 1, the first criteria is that you must have at least one manic episode. And the occurrence of the manic and major depressive episode is not explained by the schizophrenia spectrum disorder. So, for bipolar 1, all you need to do is have at least one manic episode. If you have one manic episode, immediately the diagnosis is bipolar 1. For bipolar 2, the criteria must have at least one hypomanic and one major depressive episode. Okay, so one hypomanic and one depressive episode. So for bipolar 1, just remember at least manic episode. So because in bipolar 1, even though the patient did not experience a major depressive episode, but if there is only manic and hypomanic episodes, so immediately the diagnosis is bipolar 1. But for bipolar 2, at least one hypomanic episode and one major depressive episode. Okay? The C clause is the schizophrenia spectrum clause, and the symptoms of depression or the unpredictability caused by frequent alternation between periods of depression and hypomania causes clinically significant distress or impairment in social, occupational, and or important areas of functioning. So, if you look at it, so bipolar 1 is a severe bipolar disorder. Meanwhile, bipolar 2 is somehow moderate bipolar disorder in the context of our bipolar spectrum. The third disorder in the bipolar spectrum is the cyclothymic disorder. So, cyclothymia is a milder version of bipolar. And a diagnosis requires that a person experience hypomanic episodes with periods of milder forms of depression known as dysthymia for at least 2 years. And there is a low-grade cycling of moods which typically appears to the observer as a personality trait and interferes with functioning. So, In cyclothymia, there is hypomanic episodes and mild forms of depression or dysthymia. So before you can be diagnosed with cyclothymic disorder, you must be experiencing it for at least 2 years. So this is the diagnostic criteria. So for at least 2 years, there have been numerous periods of hypomanic symptoms that do not meet the criteria for hypomanic episode, and numerous periods with depressive symptoms that do not meet the criteria for a major depressive episode. And during that 2 year period, the hypomanic and depressive periods have been present for at least half the time, and the individual has not been without symptoms for more than 2 months at a time. So, of course, the letter C, the major depressive manic or hypomanic episode symptoms have never been met. So the letter D and letter E clause are the schizophrenia clause, and of course the substance use clause. So letter F, of course, it must cause distress and impairment. So the distress and dysfunction clause. I think that's it. That's the end of our part 2. So stay tuned for part 3, and we are going to talk about anxiety and compulsive disorders. So I hope you stay tuned, and I hope you learned a lot in this video. So goodbye.